All right, welcome back for another deep dive. Today, we're going to tackle a topic that I think really sits at the heart of a lot of philosophical inquiry: disability. And more specifically, we're going to be looking at how disability intersects with our ideas of well-being, health, and relationships.
Yeah, it really kind of forces us to examine some of our deepest assumptions about what makes a good life, what constitutes health, and how we relate to each other. It's a rich area for philosophical exploration.
Absolutely. So, for this deep dive, we're going to be drawing primarily from the Stanford Encyclopedia of Philosophy entry on disability, health, well-being, and personal relationships.
This entry really offers a great overview of some of the key arguments and debates in this field. It's going to give us a really good foundation for understanding the philosophical landscape of disability.
Okay, so let's start with well-being. This is obviously a central concept in philosophy, and the entry lays out three main approaches to understanding it: experiential theories, desire-based theories, and substantive good theories.
Right, so experiential theories focus on the quality of our experiences: pleasure, pain, happiness, suffering as the measure of well-being. Desire-based theories, on the other hand, center on the fulfillment of our desires. Well-being, in this view, is about getting what you want, regardless of whether it actually makes you happy or not.
And then there are the substantive good theories, which argue that there are certain objective goods, things like knowledge, friendship, achievement, that contribute to a good life, regardless of our individual experiences or desires.
Now, when we apply these frameworks to disability, things start to get really interesting. We immediately run into this tension between how people with disabilities often report experiencing their lives and how others might assume they experience them.
Yeah, the entry points to this really interesting finding that individuals with disabilities often report levels of life satisfaction and well-being that are comparable to those without disabilities.
Exactly. And this holds across a really wide range of disabilities and measures of subjective well-being. So it's not just a few isolated cases. It seems to be a fairly consistent pattern.
Which, for a philosopher, is immediately intriguing. Because if you're coming from a purely experiential or desire-based perspective, you might assume that someone living with a significant disability would necessarily experience a lower level of well-being.
Right, and that's where the philosophical skepticism starts to kick in. Like, are these self-reports really reliable? Are people with disabilities maybe just adapting to their circumstances in a way that masks their true level of well-being?
That's a crucial question, and the entry definitely addresses it. There are concerns about adaptation, response shift, defensive coping, all these mechanisms that could potentially skew those self-reports.
So, for example, maybe people with disabilities are lowering their expectations or finding ways to cope that artificially inflate their sense of well-being. Or maybe they're just reluctant to admit how much they're struggling.
This then naturally leads us to objective list theories like Nussbaum's capabilities approach. Here, well-being is tied to having certain fundamental capabilities like health, mobility, social connection. The challenge is that some disabilities might inherently limit the full exercise of certain capabilities. So, is it even possible to achieve a good life if you can't fulfill all the items on the list?
It's a tough question, and the entry highlights this debate. Some argue that, yeah, you need all those capabilities to truly flourish. Others, like Jerome Segal, suggest that a fulfilling life is possible even without maximizing every single capability. He emphasizes the adaptive capacity of humans to create meaning and find satisfaction even within constraints.
It seems like our understanding of value, the difference between intrinsic and instrumental value, plays a crucial role here. The social model of disability really highlights this. Think of walking, for instance. For many, walking is just a means to an end. It's an instrumental good, valuable because it allows us to get around, explore. The real value lies in the activities it enables, not in the act of walking itself.
Right, and as Ash argues, that end getting around, being mobile can often be achieved through other means, like using a wheelchair or accessible transportation. So if we focus too much on the specific means walking, we might miss the fact that the end goal is still attainable.
Exactly. And this line of thinking can be applied to other sensory and motor functions as well. We often assume they have intrinsic value, but what if their real value is primarily instrumental? What if the underlying aim communication, accessing information, can be realized in diverse ways?
It's a thought-provoking idea, and it suggests that the instrumental value we assign to typical sensory and motor functions might be inflated. Disability scholars even argue that what we see as the intrinsic value of certain senses, like sight, might actually be the broader value of sensory and aesthetic experience. It's just that those experiences are usually mediated through vision.
Which brings us to this really fascinating idea. The neutrality of disability. The core argument is that disability, once we remove societal discrimination and barriers, is a neutral characteristic when it comes to well-being, much like race or sex.
But the entry is very careful to present the counter-arguments as well. There's the maximalist view, for example, which suggests that having more valuable capacities just inherently makes life better.
And then there's McMahon's point that while a single disability might be compensated for by other abilities, the cumulative effect of multiple disabilities is unlikely to be neutral. The more disabilities you have, the more likely it is that your well-being will be negatively impacted.
On the other hand, you have this counter-concept of saturation. Ash and Wasserman argue that humans have a surplus of capacities. We rarely use all of them to their fullest to achieve what we value. So even with the absence of some capacities due to disability, the remaining ones might be more than enough for a rich and fulfilling life.
This leads us to another interesting tension. As a society, we generally have a very strong drive to prevent disability, especially in those who don't yet have it. We vaccinate, we do prenatal screenings, but we don't see a comparable drive to, say, change a fetus's sex or race.
Right, there's this asymmetry that's hard to ignore. And it challenges the notion that disability is truly a neutral characteristic. If it were, why wouldn't we be just as eager to prevent it as we are to prevent other traits?
Now, Barnes, in her work, does offer a counter-argument. She suggests that our objections to things like sex selection often stem from concerns about bodily autonomy and the social costs of transitioning. And she argues that these same arguments could also be applied to interventions aimed at correcting disabilities.
That's a very important point to consider. It forces us to ask ourselves, is our desire to prevent disability really about maximizing well-being? Or is it more about societal biases and a lack of understanding about what a good life with disability can look like?
The entry also touches on the argument that disability can, in some cases, be a mere difference, or even contribute positively to a life. This is Barnes's point again. Disability can bring unique challenges and perspectives that can ultimately enrich one's life.
Right, and it's important to remember that well-being is a complex and multifaceted concept. It's not just about the absence of hardship or suffering. There are many different ways to live a good and meaningful life, and disability doesn't necessarily preclude that.
And then there's Velleman's narrative approach to well-being, which emphasizes the coherence and meaning within a life story, regardless of whether certain capabilities are present or absent.
Yes, and non-comparative accounts of harm also challenge the straightforward view that disability necessarily detracts from well-being. These accounts suggest that some states of affairs are inherently bad, regardless of whether someone is worse off than they were before or than someone else.
And of course, we can't ignore the issue of lifespan. Some disabilities are associated with a shorter life expectancy, but it's crucial to remember that this isn't always the case. And even when it is, it's philosophically contentious to directly equate a longer lifespan with a better life.
Absolutely. We can't simply assume that more years automatically equals more well-being. There are plenty of other factors that contribute to a good life, and it's entirely possible for someone with a shorter lifespan to have a richer and more fulfilling life than someone with a longer one.
All these complex considerations about disability and well-being have very real practical implications. The entry explores how they play out in areas like reproductive technologies, end-of-life decisions, and healthcare resource allocation.
Let's take reproductive technologies, for example. The decision of whether or not to continue a pregnancy when a fetus is diagnosed with a disability often hinges on assumptions about the child's potential quality of life. But, as we've seen, those assumptions can be deeply flawed.
Right, and the very notion of a life so burdened that it constitutes a harm raises huge ethical questions. Whose perspective are we privileging in these decisions? What are the potential consequences of acting on those assumptions?
And then there's the issue of parental attitudes. Parents often make decisions based on a desire to protect their child from suffering or to avoid burdens they feel ill-equipped to handle. But are those fears always grounded in reality?
The entry also delves into the ethically challenging terrain of withdrawing life support from newborns with disabilities. Disability scholars raise serious concerns about the potential for inaccurate medical prognoses and deeply ingrained biases to influence these decisions.
It's a very sensitive area, and it's easy for discrimination to creep in. Are we truly acting in the best interest of these infants, or are we making judgments based on societal preconceptions about what a good life looks like?
Similar complexities arise in end-of-life decision-making for adults who can't express their own wishes. The standards of substituted judgment and best interests are susceptible to the same biases we've been talking about.
Right. The case of Elizabeth Bouvier, who fought for the right to refuse life-sustaining treatment despite her cognitive capacity, really highlights this. She felt that her quality of life was unacceptable due to her physical dependence, but others argued that she was being unduly influenced by societal prejudices against disability.
And finally, the entry looks at health-related quality of life measures, which are often used to evaluate the cost-effectiveness of healthcare interventions. The problem is that the methodologies behind these measures often treat adaptation to disability as a distortion of true health and include functional limitations as negative outcomes. This can lead to systemic discrimination against people with disabilities in healthcare resource allocation.
Exactly. We see this in things like the Oregon Healthcare Plan and the Global Burden of Disease Framework, where the value of life years for individuals with disabilities is often discounted based on assumptions about their quality of life. These assumptions, as we've seen, are often deeply problematic.
Okay, so we've explored the relationship between disability and well-being, and we've touched on some of the ethical challenges that arise in healthcare decision-making. Now, let's shift our focus to health itself.
Right, because there's this interesting tension that emerges between the social model of disability, which focuses on civil rights and social justice, and the very real healthcare needs that many people with disabilities have. So can someone with a disability truly be considered healthy? What even counts as health?
To answer that, we need to grapple with different philosophical understandings of health. The entry outlines several, from the basic definition of health as the absence of disease to broader conceptions that encompass well-being and flourishing.
Right, so on one end of the spectrum, you have very simple definitions that focus on biological normality. Health, in this view, is just the proper functioning of the body's systems. Anything that deviates from that norm is considered unhealthy.
But then you have these more expansive views, which recognize that health is about more than just the absence of disease. It's about the capacity to live a full and flourishing life, to achieve your goals, to connect with others.
And within these broader conceptions, there's also debate about whether health is intrinsically valuable or instrumentally valuable. Is good in and of itself, or is it valuable because it allows us to do other things that are valuable?
The entry highlights some of the key philosophical accounts of health, like Bors's biostatistical theory, which defines health in terms of species-typical functioning. From this perspective, disabilities are inherently unhealthy because they deviate from the norm, but this doesn't mean they necessarily make life bad.
Right, and Daniels builds on this by emphasizing the importance of healthcare for maintaining fair equality of opportunity. So while disability might be considered unhealthy from a biostatistical perspective, we have a moral obligation to provide health care to mitigate the disadvantages it might impose.
Amundsen offers another helpful distinction, the difference between disease and disability. He argues that a disease is an underlying pathological process that can lead to disability, while disability is the actual loss of function at the personal level.
This distinction has important practical implications. It suggests that our response to disability shouldn't always be medical. Sometimes the most effective interventions are environmental or social things, like making buildings accessible or changing social attitudes.
But of course, there are counter-arguments. Hausman, for example, challenges the idea that someone who's blind or paraplegic can be considered healthy, even if their underlying biological systems are functioning properly. He argues that there's something intuitively wrong with that claim.
And then you have Hochland-Broich's harm-oriented account of health, which defines it in terms of the absence of specific harms, like death, suffering, infertility, or an inability to participate in community life. This approach tries to ground the concept of ill health in tangible negative consequences for the individual.
Despite these efforts to draw clear distinctions, the entry acknowledges that in practice, it's often difficult to neatly separate disease and disability. Legal definitions tend to blur the lines, and many disabilities are associated with underlying diseases. Plus, societal priorities often favor addressing diseases over accommodating disabilities.
And this really reflects the complex interplay between biological, social, and environmental factors. Disability is not simply a medical issue. It's shaped by social attitudes, cultural norms, and the built environment.
The entry also explores broader conceptions of health that go beyond the mere absence of disease or disability. Instrumental views like Nordenfeld's focus on vital goals and Venkatapuram's emphasis on basic capabilities expand our understanding of what it means to be healthy.
And then you have positive conceptions of health, like Becker's, which incorporate things like resilience, robust agency, and the capacity to adapt to challenges. These views recognize that health is not just about avoiding negative states, but also about cultivating positive attributes that allow us to thrive.
Now, let's move on to personal relationships. The entry starts by highlighting the strong connection between strong personal relationships and well-being. But there's this pervasive assumption that disability is a major obstacle to forming those relationships.
Right. People often assume that people with disabilities are less likely to have friends, find romantic partners, or start families. But disability scholars argue that these perceived barriers are largely social and environmental, not inherent to disability itself.
So, what exactly are we talking about when we talk about personal relationships? The entry focuses on enduring, intimate connections characterized by things like mutual regard, self-disclosure, and shared understanding.
Right. It's about those deep and meaningful connections where we feel seen, understood, and valued. And while there's often an element of reciprocity in these relationships, it doesn't necessarily require a strict equality of exchange in every single area.
Philosophically, the concept of equality in friendship has been debated for centuries. Contemporary views tend to emphasize equality of respect, investment, and commitment, rather than things like social status or abilities.
And that's really the question here. Does disability inherently prevent this kind of fundamental equality within relationships? Can people with disabilities truly experience the same depth and richness of connection as those without disabilities?
It's striking how much of the philosophical and bioethical discussion around relationships involving disabled individuals has focused on the perspective of the non-disabled person. We often talk about the burdens and challenges faced by parents of children with disabilities or adult children caring for their disabled parents.
Right. And we often overlook the perspectives of the disabled individuals themselves. It's like we assume that the goal is always to have relationships with non-disabled people, even if those relationships are unequal or burdensome.
The entry really challenges this assumption and highlights the importance of centering the experiences of disabled individuals. It also points to the unique dynamics within relationships where all parties have disabilities, which are often completely absent from these discussions.
This bias can also distort our understanding of peer relationships. We might assume that disabled individuals are less capable of forming deep friendships or participating in social activities. But these assumptions often reflect a narrow and ableist view of what friendship looks like.
The entry introduces the human variation model as a way to reframe these questions. Instead of seeing disability as a binary disabled versus non-disabled, this model views it as part of the spectrum of human diversity. It emphasizes the interaction between individual differences and the environment.
Right, so instead of asking whether disability inherently limits someone's capacity for friendship, we can ask how the environment can be adapted to facilitate those connections. It's about recognizing that everyone has different needs and abilities, and that those differences don't have to be barriers to meaningful relationships.
Another important point is how disability can sometimes loom large in people's perceptions, overshadowing all other qualities. It's like one characteristic becomes the defining feature of a person, preventing others from seeing their full humanity.
This phenomenon, which the authors call synecdoche, can have a profound impact on intimacy. If someone only sees you as the disabled person, it can be very difficult to form those deep and vulnerable connections that characterize true intimacy.
And this is especially relevant when we talk about romantic love and sexual intimacy. Non-disabled individuals might have doubts about the capacity of disabled people to be fulfilling partners, or they might struggle to imagine a relationship that meets their emotional and physical needs.
These doubts are often amplified by social factors. People who experience disabilities early in life might be excluded from typical social learning experiences related to sex and relationships. Sex education might be lacking, or they might be exposed to harmful stereotypes that portray disabled people as asexual.
And these challenges can continue into adulthood. Disabled individuals often face cultural prejudices, patronizing assumptions, and internalized psychological barriers that make it difficult to form romantic relationships.
But it's crucial to remember that these are social and cultural barriers, not inherent limitations. The entry highlights many examples of disabled individuals finding love and navigating the complexities of sex and relationships in fulfilling ways.
Parenting is another area fraught with assumptions about disability. Many prospective parents express reluctance to have a child with a disability, often due to fears about the burdens of caregiving and concerns about the child's quality of life.
This reluctance is often particularly strong when it comes to cognitive impairments. People seem to have a harder time imagining a fulfilling life for someone with an intellectual disability, and they worry about the challenges of communicating and connecting with their child.
But research actually paints a more nuanced picture. Studies show that families with children with disabilities often report levels of satisfaction and well being comparable to those without disabled children.
Of course, there are unique challenges, and those challenges can be significant. But the point is that disability doesn't automatically negate the possibility of a loving and rewarding parent-child relationship.
And then there's the skepticism that disabled individuals themselves often face about their capacity to be good parents. This often reflects deeply ingrained prejudices and a lack of understanding about what parenting with a disability can look like.
It's like we assume that disabled people are incapable of providing the care and support that children need, even though there's plenty of evidence to the contrary. This really highlights the need to challenge our assumptions and listen to the experiences of disabled parents themselves.
The entry concludes with a discussion of personal relationships and the role of third-party assistance. Some disability theorists argue that the assumption of unique difficulties in relationships involving disabled individuals stems from a narrow and potentially ableist understanding of mutuality.
To address this, they advocate for separating instrumental care needs from the intimacy inherent in close relationships, often proposing state-subsidized personal assistance services. This allows individuals with disabilities to receive the support they need without relying solely on their loved ones, preserving the mutuality and interdependence that are essential for healthy relationships.
This idea has sparked some debate. Some argue that relying on third-party assistance undermines the claim that disability isn't a barrier to intimacy. But advocates counter that it's the social stigma surrounding disability-related needs, not the needs themselves, that creates the barrier. Providing adequate support can help dismantle those stigmatizing attitudes.
Now, not all disability theorists fully embrace the concept of outsourced care, though. Some, like Wendell and Kitty, emphasize the value of interdependence and kinship caregiving, suggesting that those experiences can teach us valuable lessons about human connection and mutual reliance.
But the entry ultimately concludes that ensuring professional caregiving is a dignified and accessible option remains crucial, especially when kinship care might place undue strain on intimate relationships. The goal is to empower individuals with disabilities and their loved ones to define the terms of their relationships autonomously, with the option of external support when needed.
So to sum up this deep dive, the key takeaway for our philosophically inclined listeners is that disability doesn't inherently negate the possibility of a good life, a healthy life, or fulfilling personal relationships.
Many of the negative assumptions we hold about disability simply don't hold up under philosophical scrutiny, and it's crucial to center the voices and experiences of disabled individuals in these discussions.
This exploration really highlights the importance of challenging our biases and recognizing the vast diversity of human experience. Our understanding of well-being, health, and relationships is enriched when we include the perspectives of those who have been historically marginalized and excluded.
And it leaves us with a final, thought-provoking question. How might a deeper engagement with disability studies and the lived experiences of disabled individuals transform our core philosophical frameworks? How can we move beyond a narrow and ableist perspective to embrace a more inclusive and nuanced understanding of what it means to be human?
It's a question worth pondering, and it's one that can lead to a richer and more meaningful understanding of ourselves and the world around us.